And our next speaker is Ed Wilson, speaking about persistent fetal vasculature cataracts.
Now, you know, these persistent fetal vasculature cataracts come in all sizes and shapes and flavors. So here are just a few pearls and some video. Infants with mild PFV in the infant aphakia treatment study did have more adverse events, but they had similar outcomes. And we excluded in that study any severe PFV that had stretched ciliary processes. We just recently in the AJO published a series of severe PFV, so those with stretched ciliary processes but no retinal involvement, and we rarely had final visual acuity better than 2200, reoperation rate of 60% and 18% glaucoma. So those cases are the ones that are often excluded from your clinical trials, and we looked at them. Those are the tough cases. Here is just a video done by one of our residents. These three cases that he linked together came in the same week. So this one you see after you do the capsulorhexis, things are looking good, and then there's the big stalk. Of course, we knew it was there by ultrasound. And we had to disconnect these radial attachments to the vitreous that those stalks often have. Here's another case where after the capsulotomy, now to the one side you can start to see that there are ciliary processes stretched. There's a thin stalk, and what I've learned is in these cases to reduce reoperation rate, you really need to get rid of the traction, get those ciliary processes to revert back. Now this last case, that was intralenticular blood. And the only time, if you open a capsule and you see intralenticular blood, then you know you're dealing with persistent fetal vasculature. And again, these are pretty typical cases. You can put an intraocular lens in some of those cases. You really have to take them on a case-by-case basis. Now, we all know that they can also look like this. And so when you're talking about persistent fetal vasculature, or the old term of PHPV, you really have to specify, are you talking about the mild ones with a small stalk that you can approach much like you would approach a regular case, or are they like this? Now again, I think the pearl is you have to relieve the circumferential traction and get the ciliary processes to go back to their original position. If you cut a hole in the middle of this and leave a platform for an intraocular lens now or later, this will reopacify pretty frequently. So I think the key is to get, even if you have to cut between every ciliary process to get the material to release and get the processes to go back where they belong. So PFV is a spectrum, and it depends on how broadly you define it. If you define it very broadly, then it's significantly more common than has been previously reported. And we think that it probably should be defined more broadly. So there's not really one approach to all of the PFV cases. It really has to be customized case by case.